Hello friends, I hope you all are doing great. In today's video, I am going to discuss about the lymphoid. So let's begin. So in lymphoid series, we have the maturation from lymphoblast to the prolymphocyte to the small lymphocyte. Now the first cell is the lymphoblast, which is here we see the size is the 10 to 20 micrometer and C ratio is decreasing from downwards. This is 4:1, 3:1. This is much smaller. Now the chromatin of the lymphoblast is smudged and with having 1 to 2 nucleoli. So these are the features for lymphoblast. Then the prolymphocyte size is somewhat smaller than the lymphoblast, and C ratio we already discussed. Nucleoli may be present and the coarse chromatin. Then the small lymphocyte is the in body the lymphocyte there is 90% is the small lymphocyte, which is the approximately 9 to 12 micrometer in size, which contain dense chromatin clump, and the 2/3 among them are the T lymphocytes, 2/3 for T. Now the large lymphocyte, they are of 10%, with having the larger size is equals to 12 to 16 micrometer than the small lymphocyte, and they have less condensed nuclear chromatin. Now then the large granular lymphocytes, it is generally normally present around 5%. If it is more, we have to rule out some causes for the large granular lymphocyte, and the abnormal elevation may occur in patients with viral infection, neutropenia, red cell aplasia, and the RA. Okay. Then the plasma cell, the normally no plasma cell is seen in peripheral smear. It can be occur in bacterial or viral or drugs or the multiple myeloma, which is the commonest finding, and SLE. The diameter is larger, somewhat between the 14 to 18 micrometer, with the deep blue cytoplasm and having the perinuclear clear zone. Perinuclear clear zone. This is due to Golgi body. Due to. Okay. Now either we further discuss the immunophyllotyping for the plasma cell, as the normal plasma cell is CD38 positive, CD138 positive, CD19 positive, CD20 positive, while plasma cell in multiple myeloma is positive for CD38, CD138 and CD56, but negative for CD19 and CD20. Now according to the percentage of plasma cell in peripheral smear, we can diagnose the condition, like it is present less than 10% in Waldenstrom macroglobulinemia, then the more than 10% in smoldering multiple myeloma, and if it's more than 20% is seen in plasma cell leukemia. Okay, now go the further is our atypical lymphocytes. It is a diverse in appearance, larger, oval, kidney shaped, lobulated nucleus, nucleoli sometimes prominent, here the prominent, then the abundant cytoplasm, and the commonly vacuolated or foamy. It is commonly seen in Epstein-Barr virus, which is related to infectious mononucleosis, but also with cytomegalo and HIV. Now in infectious mononucleosis, there is the atypical lymphocyte is known as Downy cell. Other name of this atypical lymphocyte is monocytoid lymphocyte, which can be seen in infectious mononucleosis. Okay, now go further is the plasmacytoid lymphocyte. It resembles like plasma cell but having dark blue cytoplasm, and the nucleus is also eccentric but comparatively less, with having the absence of perinuclear clear space, which is seen in plasma cell due to Golgi body. This may form in viral infection, lymphoma, multiple myeloma, and violence from macroglobulinemia. Now, the smudge cell is the fragile lymphocyte ruptured during the preparation of smear and creating the smudge. It is the not specific for but commonly seen in CLL. Now, we discuss the causes for lymphocytosis. First, I have subdivided it into viral infections due to leukemia or due to some other infection. Now, in viral, common is, as we already seen, infectious mononucleosis, in which the Downy cells seen, then the cytomegalovirus, Epstein-Barr virus, hepatitis A and B. Leukemia, as we know, in lymphoid series, it will be increased in acute lymphoblastic and the chronic lymphocytic leukemia. In hairy cell leukemia, Burkitt's lymphoma and non-Hodgkin's lymphoma. Other infections like tuberculosis, brucellosis, syphilis can be congenital or secondary syphilis. Then in rubella, toxoplasma and whooping cough. So these are the common causes of lymphocytosis: viral infection, leukemia and other infections. Now the causes for the lymphopenia, which is, or again the viral infection is the heading, which is seen in HIV and SARS, as we know in the COVID-19. And the other are the marrow suppression, pancytopenia, or the drugs like vinblastine, chloramphenicol, and doxorubicin. Now, here I am presenting a case which came across our hospital. The history was around 3-year female with HB 2.9 gram. Her TC was around 4,600. Platelet was 24,000 cells per cubic mm. In DC, there will be 82% of lympho. Here we can see the age is less, platelet is also decreased, but TC is normal and HB is decreased. So these three conditions suggest us the acute type of condition. But as the TC is normal, to define it as a leukemia, it a little bit difficult. But the cells seen on the smear are mainly of this type, which correlate as the 1 to 2 nucleoli, scant cytoplasm, and the clump chromatin, which leads to its lymphoblast. All the many cells, around 70 to 80% cells, are of this characteristic. So it was diagnosed as acute lymphoblastic leukemia. As I discussed in my earlier video of leukemia approach, here the TC is normal. So we can subdivide this into subleukemic leukemia. I hope you enjoyed this. Thank you.